Hi, this is Dr. Joannides, Chief Medical Director at Optimum Re, and this is the Optimum Academy Prostate Cancer 101, video number 2. It's about staging, treatments, and ratings for prostate cancer. So let's get started. So the clinical classifications using the TNM format for prostate cancer are shown here. This is the clinical staging. So the T classification is preceded by a small c. And so you can see what T1 type stages of prostate cancer look like. One that may be often seen is the bottom one, which is T1C, and that means that the tumor was identified in the prostate by needle biopsy, which was likely done because of an elevated PSA. This is not equal to in situ prostate cancer. It's prostate cancer that was found on biopsy of the prostate. So some people get confused that this is in situ. It's just a positive needle biopsy. That's all it indicates. So here's the rest of the TNM classification. And you'll notice under T2, the tumor is confined within the prostate. T2A involves 1/2 of one lobe or less. T2B involves more than 1/2 of one lobe, but not both lobes. And T2C involves tumor in both lobes. Then the more worrisome prostate cancers are T3, which extends through the prostate capsule, like T3A, which is extracapsular extension, unilateral or bilateral, and T3B, which is invasion of the seminal vesicles. And then T4 is a much more worrisome situation where the tumor is fixed or invades adjacent structures other than the seminal vesicles. So those are cases we would be unlikely to consider for life insurance. Now there are some, I may call them zealots, who are considering now that Gleason 3+3 prostate cancer on biopsy is not cancer, especially a Dr. Klotz in Canada. However, even Johns Hopkins says the following, that Gleason 3+3 equals 6 is not cancer. It's not aggressive and may never need treatment, but then again it might. So it's not cancer. So we should still be concerned if Gleason 3+3 is present, and even if somebody undergoes active surveillance, it should still be followed as prescribed under active surveillance guidelines. So if somebody has a prostate removal using robotic surgery, it's called a robotic radical prostatectomy. And here's sort of what it looks like. A lot of probes and trocars are put into the abdomen. The patient rather is in the operating room and has these inserted, and then they're connected to the robotic arms. And then in a separate room, the surgeon is sitting at a module to actually utilize those instruments from a separate room. There's an anesthesiologist hopefully present in the room with the patient in the surgical suite, but the actual surgery is being done from a robotic module in another room. And by the way, when these trocars are placed into the abdomen, CO2 is injected into the abdomen to blow it up like a basketball. And what that does is it applies a continuous positive pressure, kind of like a CPAP, in the abdomen. And what that does is it puts pressure on all the little capillaries and venules and arteries, and so there's less bleeding during the surgery, so less need for blood transfusion. So it has a positive effect. After surgery is over, they drain most of the CO2 out of the abdomen, although the abdomen may still be fuller than usual because some of the gas is still present there. And The reason you do robotic surgery like that is you don't need a huge incision as was done in the past, and the prostate can be removed through a small incision, and then each of these holes from the trocars can be easily closed, and so there's less healing necessary, so a shorter recovery time, which is all to the benefit of the patient. There are other options instead of surgery for treatment of prostate cancer, including CyberKnife, which is basically a huge machine that's shown on the upper left. There's proton beam treatments, and then there's the old external beam radiation shown in the middle that blasts the tumor cells. So these are basically designed to, from the exterior, treat the tumor in the prostate without requiring surgical intervention, and they may get most of the tumor, hopefully all of it. However, they may not wipe out the entire prostate, so that's why following one of these treatments, the PSA level may not be undetectable, but may still show some residual level and need to be followed in that regard. There's also something called cryotherapy or cryoablation or cryosurgery that uses freezing temperatures to destroy cancer cells. So you may see that reported as well. We don't have that specifically outlined in our manual. We just mentioned it, which I will report later. Now, one of the other, if you want to call it, treatment modalities for prostate cancer is, in some cases where it appears there's low risk of the prostate cancer causing metastatic disease, active surveillance is used, and it's a monitoring program for men with favorable risk prostate cancer who choose to defer definitive treatment. So the aim is to individualize treatment by contrasting with what's called watchful waiting, which is no treatment whatsoever and avoids all treatment for the future. The patient is monitored closely with PSA testing frequently and active surveillance and repeating prostate biopsies if necessary. If treatment becomes necessary, it would be one of those definitive treatment modalities we just talked about. And it is advised for many early stage, low-grade cancers to avoid the complications of treatment. And it's a decision that would be made with the patient and the urologist in combination, deciding what's the best method to treat or follow the patient in the future. Watchful waiting, on the other hand, is essentially no further treatment. It may be used in people that are significantly impaired already, not surgical candidates, or have some other health concerns. They may have Alzheimer's disease, etc., and not be great candidates for surgical intervention. It differs significantly from active surveillance. So what are red flags in prostate cancer? Some medications are used when there's a biochemical failure. So in other words, whatever treatment was employed, it wasn't successful, and the PSA level is rising to a level that's worrisome after treatment has been done. So if surgery was done, any rise in PSA would be considered a biochemical failure. If radiation was used and the level goes up to a high level, that would also indicate that the prostate cancer has not been effectively treated. So if you see medications such as I've outlined here in yellow, Casodex or something along these lines, or there's alkaline phosphatase elevation after prostate cancer treatment, those are red flags that would be of concern, since it appears that there was a failure of the initial prostate cancer treatment. Now, new with the latest AJCC edition of How to Stage Cancers, for prostate cancer, Gleason scores are now grouped into what are called grade groups. So this is relatively new. It may not be in all manuals, but it's something to be aware of. It is now in our Optimum manual. So a grade group 1 would be Gleason score of 6. That would be 3 plus 3 or lower in a pattern of 3 plus 3 or lower, as I said. Grade group 2 would be Gleason score of 7 with a pattern that shows 3 plus 4. So if the initial pattern when looking at the slides is 3 and then there's some 4 on the side, that would be a 3 plus 4 equals 7. Grade group 3 is also a 7, but it's more Gleason grade 4 than it is Gleason grade 3. Then grade group 4 is Gleason score of 8, and grade group 5 is a Gleason score of 9 or 10. That's pretty worrisome. So how does this fit into our prostate cancer staging? So let's follow along here in the columns. So initially you get your T stage, correct? Then your N stage for the nodes, and then the M stage or metastasis. We're not taking any metastatic prostate cancer cases for life insurance. Then you look at the PSA level. So that's another determinant. How high was the PSA level at the time the treatment or the diagnosis was made and treatment was indicated? Then we use this grade group that we just talked about. Is it a Gleason 6, which would put you in a grade group 1, or is it a higher grade group that would put you in a 2, 3, 4, or a 5? And then we have at the far right the final stage. So when we think about ratings, and this is in our manual, the Optimum manual, rating considerations for all treatments, and this is a litany of all the things to be concerned about when a patient has undergone therapy with one modality or another, and how to handle any permutations that are listed here. So for instance, let's say in the red it says if treatment is other than radiation, surgery, or surveillance, and that includes HIFU or that cryotherapy, rate as surveillance. If treatment is observation, no treatment and no plan of monitoring, refer to the MD, and that's usually RNA, and that would be somebody who is supposedly just having watchful waiting where no treatment whatsoever is planned, no matter what happens. And then you can see all the other provisos that are listed here in the rating section, which you can read at your leisure. So what I really wanted to highlight was the mandatory follow-ups. So for surgery, if margins were not clear at the time of surgery, in other words, it says the margin was involved with prostate cancer, the case is then a decline because you don't know how extensive the cancer was in going to the localized or regional areas around the prostate. After surgery, you must have PSAs that are basically undetectable and stay so. So the PSA level will usually be reported as less than 0.1 nanogram per milliliter or something that's in that range, very low levels, less than whatever. If any PSAs are noted higher than that, it may be a biochemical failure, meaning that the surgery, although it lowered the PSA, it wasn't completely effective and maybe there's a recurrence or not all the tumor was removed. For radiation without surgery, the PSA after radiation should trend downward and become less than 1.0 nanograms within 12 months. It should stay at a low level. If it rises above 1.0, I start getting concerned. So, we usually follow the trend of the PSA after radiation, but if it starts spiking up, that's a bad sign. and should be referred to the RM or referred to the medical director. And then for active surveillance, there's a lot of mandatory requirements. So this isn't like a hall pass or a get out of jail free pass. If you have prostate cancer and you're on active surveillance, you have to have rigorous follow-up testing in order to comply with the ratings here. So the PSA should be done at least every 6 months in follow-up. If the PSA is increasing, then the PSA velocity should not exceed 1 nanogram per milliliter per year, and the PSA should not exceed 10. There should be no clinical progression of disease, so no enlarging nodules and no radiologic progression, so no increased size of suspicious areas on MRI or ultrasound. Repeat biopsy should be performed within 12 months of initial diagnosis and show no progression of Gleason grade. So a repeat biopsy is required within 12 months of initial diagnosis. If that hasn't been done, then active surveillance ratings are not available. And a repeat biopsy should be done within 2 years of application for all applicants under age 65 and within 3 years for all other cases. So you can see there's a lot of mandatory requirements for somebody to be rated using our guidelines for active surveillance. And it says at the bottom, if follow-up is not consistent with the above, risks are not acceptable. So, those would be declines. And what's this biochemical failure I was talking about? So if the PSA was less than 0.01 after surgery but starts creeping up, that's considered a biochemical failure and requires some additional form of treatment, and you may want to send that to the MD. We have ratings in our guide, and the ratings are segmented by age less than 60 or 60 plus for each stage, and then we have it broken out into whether the person that's applying got surgery for treatment, radiation, or surveillance. And they have to meet all those requirements for surgery, radiation, and requirements that I just went over. And then we have the ratings to the right. I have blue boxes or a blue box over them, since some of the people watching this video may not be clients and we can't release our ratings to anyone who is not a client of Optimum Reinsurance. So we have full ratings for all the different stages and whether they've been treated with any of those particular treatments. So I have some cases. First case is a 52-year-old hedge fund trader with a PSA of 8.9. He's diagnosed with Gleason 8 prostate cancer on biopsy. So yes, his stage is recorded as T1C because it was done by biopsy. That's all we've got. We don't know how extensive the disease is. All we know is that his PSA was 8.9 and he had Gleason 8 on the biopsy. His urologist advises definitive care, but the applicant prefers active surveillance. So he's only 52. He's a hedge fund trader, so he deals in high risk, and he decides to roll the dice and go with active surveillance, even though he has a Gleason 8 on his prostate biopsy. A PSA 6 months later is 8.5. He hasn't had a repeat biopsy. So what would your rating be? So to me, no matter what our guidelines say, this is worrisome because he's a young man and he has a Gleason 8 cancer, and that's all we know. His PSA hasn't risen, but he's kind of playing with fire here. So in certain cases, this might not be a candidate you want to take at this point in time without any definitive treatment, but I'll leave you and your guidelines that you may be using for people with active surveillance. Case number 2 is a 75-year-old male executive with a history of increasing PSA. Was recently 6.5. He had a biopsy and one of 12 cores was positive for Gleason 3 + 3 = 6. He and his urologist have decided on active surveillance. And, our guideline would be very favorable toward this. So he figures, why not cover his risk? And so he's applying now for $10 million of life insurance and wants a standard rating. So you have to think about, what would you do? I mean, it looks like a favorable type case, right? His PSA is kind of within that normal range for his age group. Only one of 12 cores was positive, and it was a 3+3. He's at 75. But he's basically transferring his risk, however low that might be, to whoever accepts his $10 million life insurance application. So he's transferring his risk. So, you would think about what would be the best situation for you and your life insurance company if you were underwriting this case. So case number 3, a 41-year-old male has a family history of prostate cancer in his father at age 56 and 2 uncles, brothers of his father at age 57 and 58. His mother died of ovarian cancer at age 62. He has a PSA of 0.8 a year ago, but his PSA last month was 2.7, and his urologist treated him for possible prostatitis with Cipro. The doctor advised another PSA in 6 months. Can we accept for life insurance? So just some things to think about here. Number one, he has a strong family history of prostate cancer. Men in their 50s in his family seem to develop prostate cancer. And another interesting feature is his mother died of ovarian cancer at age 62. We don't know exactly what circumstances were or if she had any genetic testing, but if let's just say she was BRCA positive, that would put him at additional risk for prostate cancer as well. So these are things to consider. Also, you can see the velocity of the PSA over the last year. Went from 0.8 to 2.7. That's a pretty fast rise. It could be it was due to prostatitis, but you'd want to closely follow, if you were just going to follow his PSA, to make sure that it went down after that treatment for prostatitis, if that was what the case was. So again, in this young person, concerned about possibility of prostate cancer. And in case number 4, a 67-year-old male had an elevated PSA of 11. That's concerning. And a biopsy that showed Gleason 4 + 3 = 7. He had a radical prostatectomy 5 years ago, and there was slight extension through the prostatic capsule. So additional periprostatic tissues were removed. The immediate post-op PSA and at 6 months was 0.01, but a recent PSA was 0.7, and his urologist put him on Casodex. So what would your rating be? So what I wanted to highlight with this was, first of all, his PSA was 11 when he was initially treated. That's high. Over 10, that's worrisome. He had a Gleason 7, and it was a 4 + 3, 7. So more 4 than 3. That's worrisome. He had a slight extension through the prostatic capsule. We know that that would be at least a T3 type staging of this prostate cancer. And the rise in his PSA showed he's a biochemical failure. So this would not be someone who's acceptable for life insurance, at least with us. So what are the takeaways? So the best cases are lower stages, T1 and T2, and lower grades like a Gleason 3 + 3. That should be 3 + 3 = 6. A radical prostatectomy surgery is more definitive than radiation, which is more definitive than active surveillance. And then we had all those mandatory follow-ups that I described in detail, that to meet any of the ratings that we offer for surgery, radiation, or active surveillance, you have to meet those follow-up requirements, or else the case would not be considered favorably.